Two clerks, yeah, okay. So what we're going to do is we're going to present a couple of cases, and we're going to try and see if we can figure out, you know, what's going on with these patients. What I've realized over the years is ophthalmology is not, you know, it's one of those fields that, to me, the residents don't get a huge amount of training in, and certainly it's a field that, you know, it's a little bit, you know, they're unsure about most of the times, but using equipment and so forth. So I'm hoping to bring a few cases here just to hopefully alleviate some of this anxiety. I do have quite a few slides. We only have half an hour, so we'll try and get through as much as we can. So the first case is a 60-year-old female with diabetes who had loss of vision in one eye over a few minutes, a sudden loss of vision. No trauma, no eye pain, no nausea, no vomiting. Just ophthalmology findings. She had a normal external eye and eye movements. A red reflex was present. Normal acuity on the left, but only hand motion on the right, which is the side she was complaining. The relative afferent pupillary defect was positive, and a normal fundoscopy on the uninfected eye. So the first question I'm going to ask is, what is the RAPD? What does that mean? So relative afferent pupillary defect, what does that mean? Anybody?
It's an inappropriate response in the alternate eye to the swinging flashlight test.
So well, what exactly are you testing? Well, what exactly it's a defect of?
Of the cranial nerve, optic nerve.
So the optic nerve, yeah. And how do you do? What does it test? Well, what exactly happens? What is a positive test?
So the normal response would be that you shine the light in an eye, and you have consensual constriction of the pupil, and you get inappropriate dilation with a relative afferent pupillary defect. Yeah.
So that's what you get, is when you shed light in the pupils, you normally get a constriction, and with the affected eye, you get dilatation. And the reason why is because the optic nerve is still trying to pick up some light. So the response to that is to dilate the pupil to get more light into it, which is simple. So that's what a RAPD is. And it's a sign of optic nerve injury or damage. So just based on that sort of case, anybody has any thoughts of what could be going on? So sudden loss in one eye, affected visual acuity, and the RAPD is positive. Anyone?
I guess I just go to my differential for painless monocular vision loss, and she's diabetic, so she could have a CRAO or CRVO, but you probably see some other findings on exam. Vitreous hemorrhage, retinal attachment are the two that I guess I've seen myself in the emerge. If she had any other symptoms, you'd worry about like an optic neuritis, but it doesn't sound like she did.
Okay, so this is what you see on fundoscopy. What are we seeing here? Anyone?
The cherry red spot, or the pallor with the cherry red spot there.
So the cherry red spot, and there's sort of central pallor. Everybody appreciate that? Yeah. Again, so this is central retinal artery occlusion. I don't know if you can see in the middle there, it's that pallor and edema, and that's just because the blood vessels are blocked, so there's less blood flow. And that cherry red spot, what is the cherry red spot? Well, what does that signify? Anyone?
I believe that's the macula, and it's got a different blood supply other than the retinal artery.
Yeah, so it's the blood vessels around the fovea that it's got a different blood supply, as you say. So it's spared. So that's why you get a cherry red spot. So how common is this? Anyone? So it's not that common, more common in males than in females, tend to happen more in the elderly. Most likely cause is still emboli. So the question is, when you see this, who do we send them to? As I say, majority are due to emboli. As you say, it's usually the central retinal, but you can get a branch retinal. So the central retinal tend to cause more visual, visual defect, and the branch retinal, which tends to cause certain scotomas. But emboli is still the number one cause. I'll move my screen. Okay. All right, and that's just another picture. So the cilioretinal, that's the fovea, which you get parent, so you get a big cherry red spot. Right, so causes, embolytic is the number one cause. As I think it was Mark was saying, is the temporal arthritis, vasculitis, sickle cell trauma can cause this, and thrombosis is a cause. Treatment, anyone?
So treatment would be like initially you can try like massage, and then different methods to try to lower IOP, I believe. And then potentially a call to IR for localized thrombolytics, I believe, and then involvement of ophthalmology.
Yeah, so digital massage, firmly press pressure for about 15 seconds, release and repeat. So that's decreasing the pressure. You have, I'd say, IOP lowering drugs, which is your beta blockers, your carbon anhydrase inhibitors, your alpha antagonists. And then there's vasodilation techniques, which is rebreathing with an increased PCO2. Some people say also high flow oxygen helps. So there are different things that some people have tried. According to the ophthalmologists, a lot of them don't really work. And they claim the best treatment is done within 90 minutes of these symptoms. So after 90 minutes, the majority of patients would probably present after 90 minutes of the symptoms starting. A lot of these techniques don't really work. And there are other techniques where they go into the eye and they inject fibrolytics. So there are different methods they've used over the years, but again, nothing really is that beneficial. So these patients, I mean, with the embolus, sometimes they'll get better, sometimes they don't get better. So really and truly, it's expected treatment mainly for these patients, but certainly you can try those techniques. And of course, your treatment is ophthalmology, neurology. Of course, is emboli. We tend to, in our department, refer more to neurology. TIA clinic is kind of where we send people most of the time. And I think that's a fair enough disposition for these patients. Because majority of these things are medical reasons. Any questions on that one? So what we're going to do is case 2. So there's a 60-year-old diabetic again who complains now of progressive loss of vision. So not acute loss over last 2 days. No other symptoms. There's painless uniform downhill on the vision. Again, the eye movement and external eye is fine. There's reduced visual acuity. RAPD is positive again, and phonoscopy is negative. It's normal in the unaffected eye. So the big difference here, this is gradual as compared to acute. Anybody has any potential diagnoses in their head? No?
I think like posterior vitreous detachment would be one thing that occurs over a longer period. This looks like more of like a blood and thunder fundoscopy, though, which would be more of like a CRVO type picture.
Yeah, so this is a central, venous occlusion, right? So it's a little different from the artery. It's just this one comes on a little bit more progressive. The reason skipping forward is because of a little bit of time, right? So how do you manage this at 2 a.m.? Anyone? I guess you call the ophthalmologist, yeah? Most of you? Yeah. Right, so what it is it's that, as you said, that blood and tunnel, stormy sensitive appearance, and that's usually because of dilated tortuous veins. You get these disc edema, and you get these what you call flame hemorrhages. Has anyone ever seen any of it? Seen one of these? No. All right, so this is skip through quickly because of time. So this usually causes a painless macular vision over hours to days, but the vision may improve through the day. Central retinal vein impingement by laminar arteriosclerosis of the central retinal artery. That's a theory behind it, but nobody really understands it fully. Treatment, there's no known effective treatment or prevention. They may consider aspirin or anticoagulation. According to Dr. Smers, they're now using this intravitreal injection of anti-VEGF, which is a vascular endothelial growth factor. The big thing with these cases that it can present with new neoendothelial development, and that could cause glaucoma in the future. So by this intravitreal injection of anti-VEGF, that sort of prevents that. So there's treatment out there for these patients. What I'm not sure is how effective they are long term. So I say the big complication is this neovascularization, and that can cause neovascular glaucoma in future. And these patients are usually left with a poor vision. Sorry, case 3. So 50-year-old presents with a 2-day history of persistent flashing lights and floaters in one eye, as well as a tiny shadow in the corner. Normal eye movement and eye exam. Visual acuity is actually 6/6 bilaterally or 20/20. Normal visual field testing. RAPD is absent, and fundoscopy in unaffected eye is normal. Any potential diagnoses here, guys?
You worried about retinal detachment with that story, or even vitreous hemorrhage?
Yeah. So what do you do at 2 a.m. again? Would you sit in there? Would you call ophthalmology? What would you do?
Well, I mean, you'd make sure the visual fields, you have a good visual field exam to see what his peripheral loss was like, and then it's an urgent referral to a retinal surgeon if it's salvageable. You could do an ultrasound to confirm your diagnosis as well, I guess, but you'd want to protect the eye from any more trauma and get on the phone with ophtho.
Yeah, especially now, I think they want to be consulted. So I would certainly speak to them, not knowing that they're not going to probably offer any treatment in the middle of the night, but certainly to set up further treatment. So what is retinal detachment? It's separation of the inner sensory layers from the RPE, which is a retinal pigmentated epithelium. You get a tear in the retina, retraction on subretinal fluid, and you get a mechanical stimulation of retinal tissue. So risk factors, severe myopia, short-sightedness, advanced age, previous cataract surgery, blunt trauma, or family history. So usually, as you know, usually present with a sort of floaters or black spots, flashing lights, and that sort of creates an effect. They may complain of sort of this wavy distortion of objects. So the visual field effects may present as a late sign. Patients may be less aware of the superior field effects. The most common effect is actually inferiorly. And that's usually hard to detect because of the nose affects that. So the takeover with that one is the visual field effects may actually, there may not be any initially. To do fundoscopy in these people, you need to dilate the eyes. But to say, a lot of us use ultrasound now, and ultrasound is fairly good at picking up these, and of course, in the right hands. Location: the superior field effects indicate inferior retinal detachment, and detachments in superior retina is far more serious because they may extend inferiorly to form the macula and then cause loss of vision, which can be permanent. So that's what it looks like on fundoscopy. If anybody's ever seen that, but as I say, you usually got to dilate the pupil for this. And treatment, consult ophthalmology anytime of the night. It's more or less to let them know, not that they're going to do much, because they're going to need to set up, review this patient next morning. All right, so they suggest bed rest and protect the eye. I think I can't remember who mentioned that just now. And this is what an ultrasound would look like, or POCUS. You can see that waviness at the bottom there, and you can see that's the detachment of the retina. All right, so next case. So someone presents, a female with unilateral headache for 1 week, a loss of all vision in her right eye over a few minutes. No trauma. Again, external eye is normal. On the left is only hand motion. RAPD is positive. Visual field testing is normal. And fundoscopy on the affected eye is normal. Any takers on this? Well, it could be a few things, right? So pale swollen optic disc. What is that?
Is this not Crest syndrome?
What is Crest syndrome?
Oh, it's a headache associated with progressive loss in the eye. That's a posterior reversible encephalopathy. I've never seen it, but it's just one of the things.
What else could it be? Pale swollen optic disc. All right, just for time, temporal arthritis. All right. So usually presents over the age of 50, more common, I think, in females. Usually present with headache, could be jaw pain, fatigue, or chewing. Claudication, it could be a scalp tenderness also. And there's a risk of, 50% risk of the other eye could be affected. I won't get too much into temporal arthritis for time, but treatment, people send us, you talk about the ESR and start steroids and arrange for a temporal biopsy in a week's time. Next case is a 60-year-old with migraine history, complains of painful blurry vision in one eye over a few minutes. There's no trauma, unlike previous migraines. There's significant nausea, vomiting, and diaphoresis. The affected eye is red, only hand motion, unable to further examine due to photophobia. Anyone?
Okay, so like acute angle closure glaucoma would be one thing to think about. Otherwise, like an iritis might be something that I'd be thinking about initially.
Yeah, so what is that? What does this show?
So it looks like you're showing me like a hazy cornea with the conjunctivitis, and I'd suspect like acute angle closure glaucoma.
Yep. So, so the aqueous humor is produced by the posterior chambers. Is the blockage of drainage and circulation to the anterior chamber, which causes increase in, the intraocular pressure, and is usually, values of 40 to 80. Again, I mean, this is just anatomy. So the history is a sudden onset. It's usually sometimes precipitated by bending forward, dark environment, funny enough, illness or sympathetic overdrive, dilated drops, and anticholinergic medication. That's sometimes happen. So the history is usually pain, is photophobia is blurry. You can complain of halos or starbursts around, usually nausea, vomiting, diaphoresis. It may make a migraine or heart or GI. And I think we've had some M&Ms on this where patients presented atypically and it was actually missed. So do bear in mind, they can present, in different ways. As I see from the eye there, you get it, it's red and injected. The iris seems to be a little, it doesn't react. It seems to be irregular, and you see a little bit of haziness to the cornea. The anterior chamber is usually shallow. There's something called a shadow sign, whereby when you shine a light on the side of the eye, you'll get a darkness just because of the decrease in the anterior chamber and the cells. So that's just what you see with the shadow sign. So immediate after consult, trigger pain and nausea, avoid dilating drops, and lower the intraocular pressure. What treatment options we have, guys? What do you give them?
So your treatment options would be so initially analgesia and antiemetic, and then in terms of more specifically to the eye would be timolol, pilocarpine, and aproclonidine in terms of your drops, and then acetazolamide, and then mannitol if needed, and then obviously with the definitive care with laser iridotomy.
Yeah, so if part of treatment is first block the aqueous production, and that's where your beta blockers and your CAIs come in. So acetazolamide, you can give it either PO or IV. There's no evidence that one works better than the other. IV if they're vomiting. If they're not vomiting or you got a vomiting under control, you can give them PO. So that blocks the aqueous production. So to reduce the vitreous volume, you can use hypoosmotic, which is the mannitol, which works effective. And then to improve aqueous outflow, supine position, and that's where you can use a miotic agent like pilocarpine every 15 minutes. And what you do is after you initiate this treatment, I usually give them about an hour or 45 minutes and then just recheck the pressures to see if they're coming down. If their pressures are not coming down, I mean, ophthalmology needs to see them ASAP. What you find is that if you can get the pressures down, ophthalmology may say, okay, I'll see them in the morning. I'm not sure how people are happy with that, but certainly I've done that in the past, where body pressures down and ophthalmologists see them the next morning. So case 6, a 30-year-old with a recent upper respiratory infection, noticed pain and decreased vision in one eye over a few days, no trauma or nausea and vomiting. They have a red inflamed eye that's painful on motion. RAPD is positive, normal acuity, and normal fundoscopy. Again?
I think you'd be worried about having a retrobulbar cellulitis here with the painful extraocular eye movements and injected eye with a previous history of a URI.
Yeah, around the eye was fine, so there was no signs of infection. But I'm hearing you, and I agree with you. It could be, but around the eye was fine. So again, for time, so we're looking at optic neuritis. Sorry, go back on that. So it's relatively common and important cause of visual loss, usually adults, young adults, especially Caucasian women, and it may be a first manifestation of multiple sclerosis. Again, it's presumed to be autoimmune reaction. or demyelination of inflamed optic nerve. So it may be preceding a viral illness or previous episodes. It usually is monocular. Usually have pain, which is variable degree, and there's usually a visual loss, which may be exacerbated by heat or exercise. As you know, I'm sure you remember the Utah phenomena. There may be a cetroscotoma or altered, color, brightness, or depth perception. So visual acuity is usually variable. The RAPD is positive. They may have field effects or cetroscotomas. Fundoscopy is often normal, but the disc looks pale and swollen. So in terms of management, you can, consult ophthalmologists, but usually neurologists is the ones who would take these, and they may consider using high-dose steroids. Yep. So we have 5 minutes. I'm just going to run through a few other common eye conditions. So superficial foreign bodies, again, these are quite common. You get discomfort or foreign body sensation, you get a lot of watering or redness. They may be difficult to see. Initial management is put some local anesthetic. If you see it, you can remove it with the tip of a green needle, or some use a cotton, cotton on the stick, and topical antibiotics, usually gentamicin for 3 days, which is usually long enough just for it to heal. If it's left for more than 12 hours, you usually get a rust ring, and you may use the alga brush to remove or send to ophthalmology clinic. We see this quite often. So you see the top one there is the rust ring, which may or may not have a foreign body in it. And that's where we use the alga to remove it. The bottom one shows with the fluorescein stain, you'll see some uptake centrally. Bear in mind, if you don't see a foreign body, you need to look in the subtarsal area for the foreign body, because usually they hide there. So you do need to flip that eyelid if you especially don't see the foreign body on the cornea. And one of the telltale signs for foreign body under the eyelid is the scratches. Every time they blink, it scratches the cornea. And this is what you'll see when you put the fluorescein stain in. So corneal abrasions, the key with these is be careful about the high-speed particles. Abrasions may cause severe pain, unless you just look anesthetic in before. All right. They usually heal within 48 to 72 hours, and just the gentamicin ointment doesn't really affect infection, but what gentamicin ointment does, it softens up the cornea, which makes it heal a little bit faster. Eye padding is not necessary unless you have put local anesthetic and you just want to protect the eye. And this, what is this?
Dendritic ulcer.
Yeah, so it's a little bit of a dendritic ulcer, which you can see. So be careful of the full thickness that penetrates the cornea. These can cause rupture of the globe and allow the aqueous humor to escape in the anterior chamber. I'm just going to show you guys some slides here. What's the CDAL test? Anyone?
Test for extravasation of corneal or intraocular fluid from a penetrating injury.
Yeah. So when you put a fluorescein, you can see that drip sign. You can see that little line in the middle there. That's a fluorescein dripping behind the cornea. So usually it signifies a penetrating injury. So you got to bear that in mind when you're staining these people, all right? And of course, if they're penetrating wounds, you got to refer these urgently. Usually it's a high-flying object, or people are using grinders or hammers or drills. And just bear in mind, the wound might actually be quite tiny and vision might actually be normal. So you've got to bear it in mind, because sometimes the examination doesn't show it. If there's a large foreign body, like a dart or a knife, just leave it, don't pull it out. Like these are real pictures, these are not makeup. So just leave that, just cover it, cover the eye, and send that to ophthalmology. And in terms of finding the intraocular foreign bodies, I mean, CT scans and X-rays are what we use. CT scan is probably image of choice. And I say occasionally we have to do it. And again, these are just some slides showing where there's a tear of the there's a tear in the iris, all right, with leakage of fluid, and that's actually damaged the lens. So you got to bear it in mind. Again, another image showing similar. In front of squeeze, sometimes you can see the piece of metal. This is the X-ray showing it. And this is CT scan showing a foreign body there on the right, so the patient's right, left. All right, let's see, it's 10 o'clock. Should we stop there, Joanne?
Yeah, that's a good idea. It will give some people a chance to ask questions if they have any questions. It was a great presentation, lots of great pictures and reminders of the kind of things we need to think about with these patients. I guess if you ever have any concerns, we could just call ophthalmology right away. Some of the timelines can wait till the morning, but if there's any doubt, they're pretty willing to have a chat with us.
All right, as I say, I've got a few more slides. What we could do, we could put it on, I'll put it up on the EM website, so people can refer, right? Because I think we have quite a few nice pictures, right?
Yeah, it's excellent.
And but you know, I say I'll put it on the EM website, right? So there's a few other things we could have talked about, right?
Mm-hmm.
So I guess we'll stop there.
Great.
All right.